give you the award for the best panelist outfit.
Oh, that, yeah. I try to look the part, right? Even if I don't know what I'm doing.
Yeah.
Everybody on here looks much better dressed than me, I would say.
But that's the brilliance of Scrubs, is that it's still professional.
It is. I can wear them to a meeting and people think I'm doing stuff, even though I'm just lazy. It's great.
All
hey
right.
guys, it's Darren. Can you hear me okay?
Yes.
Okay, great.
All right. So just doing a last check to see if I have anything from Trish or Sarah in my inbox, and I don't. The recording has started. We have got, looks like, a fairly full load of panelists on board. All right, and we have one guest. Hi, Allison.
Hi there.
Now, before I start off the panel with introductions, I'm going to take a little bit of time, see if we get some more people to show up from our teams. I will take a moment to say that Allison has the best earrings that I've seen so far at the entire Inventathon.
Wow, those are so cool.
Wow.
Carl, is there a way that we could get a quick message up on the main board of rural health that this panel is about to start?
Are you working today, Dave?
Yeah, it helps to unmute, I guess. Yeah, I take over at 3.
Good timing.
So we'll see how it goes Saturday night. Yeah.
All right. Like I said, I'm just going to give a couple more minutes to see if we can get some more people into the room. For those of you who haven't been keeping track, Rural Health had almost 40 different pitches that were put together last night. We currently have 13 registered teams, and they're covering a wide variety of research needs and community niches. So it's going to be a really interesting pitch fest this evening. We have, for example, PeopleO, which is looking at people at risk for CKD. We've got Avatar Care, which is focusing on home healthcare providers. Let's see, the Uber of healthy eating, which I look forward to seeing how they're going to bypass copyright infringement. That's going to be a super fun one. Welcome to our incoming guests. We're going to wait a couple more minutes before we kick off the panel. Oh, hey, Aaliyah. Aaliyah, I'm Jackie. I'm one of the moderators. All right, so one thing that we're going to do, even if we don't get any participants, is still have a conversation, because this is being recorded and the participants may refer to this at any point in time after we've completed the panel. So this will give an opportunity for people to answer questions, but it's also an opportunity for you as panelists to have a dialogue together. And I think just a conversation from all of your different perspectives would be insanely valuable. Right now on this panel, we have people that are working on access to resources, we have physicians, we have innovators, we have people that are focused on policy. So I think we can get a robust discussion around the multiple facets that are rural and low resource problem people are facing. So it is 2:03. I am going to go ahead and start with the introductions. And again, part of this is going to be recorded, so it may seem a little bit overly formal for the size of the room, but this is going to be for posterity's sake. All right, so with that, I'll start. My name is Jackie Wers, and I am the moderator for today's panel. It is my privilege to introduce our expert panelists, and I've asked each panelist, after I give their brief introduction, for them to say a statement about why rural health and low resource problem solving is important to them. So to reiterate, I'll be introducing each panelist, then they'll answer the question about why rural health and low resource innovation is something that they're passionate about and serving on this panel. But before I get to introductions, I'm going to go over a couple of ground rules. The first of which is that we want to make sure that we are giving plenty of space and time for other people to ask questions. As we have a relatively small room right now, if you want to ask a question, just go ahead and raise your hand, and then I will call on you to ask your question and then start a dialogue with the panelists. Hello. All right, and then I will try and move the questions along. If we have a queue, I'll be monitoring that. But again, given the size of the room, I don't think that's going to be a huge problem. If there are no questions, then I have a couple of questions that I will start to kick off the conversation. Additionally, I will be wrangling time. So if an answer is going on a little bit long, I have the unfortunate responsibility of trying to gently cut people off. So I'm just giving you that notification ahead of time. As a last reminder, this session is being recorded, so it will be available for future reference to the participants in this track through the remainder of the Inventathon. And if you don't get your questions answered here today, please feel free to request mentorship directly using the mentor request form. Mentors are going to be available through 9 o'clock tonight, but in reality, I've already talked to many of them. They'll be available pretty much all the time because that's how dedicated they are. So if you can't get your question answered here today, please try and reach out to them directly before we get to our pitches at the end of tomorrow. All right, with that, I'm going to start by introducing our panelists. I am going to start with Darren Malinowski. He is currently the Clinical Transformation Officer with the OHSU Practice Plan and a Professor of Surgery. Dr. Malinowski's career combines medical leadership and research that focuses on improving quality and service for both patients and providers in academic, community, and government healthcare settings. So, Dr. Malinowski, why is this particular track interesting to you?
Thank you, Jackie, and thanks for the opportunity to both be on this panel with great colleagues and hear from all of you participating in the Inventathon. Can you hear me okay? Thumbs up, Jackie? Anybody else? Great, thanks guys. So I think in my role as Chief Clinical Transformation Officer, there's a lot of focus on both ambulatory operations and access as well as digital health. And prior to COVID, I think access was probably the key factor for patients in low resource settings, whether it be rural or due to other social determinants of health. And that was a limit in terms of physical clinic spots available, and then also transportation to those clinic visits. Fast forward through COVID, and it's a different scenario. We now have infinite access digitally in terms of potential, but now the challenge is still both having access to devices or internet access or digital literacy. And so while we've definitely increased the total number of visits and clinic and ambulatory opportunities for patients from all demographic groups, it's not just enough to have more availability. We want to make sure that each of the tools can be accessed by the populations that want to use them and not be limited in their access due to those other limitations. So really eager to hear ideas about how we can improve those tools for all of our populations.
Thank you so much. And thank you for mentioning digital literacy. That is a great transition into our next panelist, Steve Corbato, who is the Executive Director of Link Oregon. Link Oregon is a nonprofit that brings together the power of its partnerships to develop a high-speed, high-capacity fiber optic network that will enable enhanced data processing, collaboration, and data sharing requirements of public and nonprofit organizations across Oregon. And this ties into digital literacy because Steve and I were talking before the start of this event about how creating a network is part of the solution, but there really is a lot of work to do on that digital literacy front as well. So with that, Steve, what does this rural healthcare and low resource track mean to you, and why are you passionate about being involved?
So I guess thanks for the introduction. It's really nice to be here. the first thing I need to say is I'm actually, even though I'm leading a nonprofit, I'm based at OHSU. So by being based here, I need to think about health, and OHSU has a statewide mission, and I think that very much aligns into this. I've worked in 3 Western states, Washington State, Utah, and Oregon, over the bulk of my career. And it's always interesting to compare and contrast the states. I think there's a significant divide in Oregon. I've been in every county that's now seen a variety of socioeconomic circumstances in the various counties. Some places doing pretty well, some aren't. And I've been around the West enough to know that towns can dry up and go away. It certainly happened during the Dust Bowl, and I think in many places in Oregon, I think we're beginning to talk about that. I think on the positive side, one outcome of the pandemic is that people appear to be leaving large metro areas, and there's an opportunity for those communities to pick up population, to pick up people with skills. But a critical component for those communities will be broadband. And when people will make relocation decisions, the viability of broadband is a key part of that. By virtue of my job, I spend a lot of time thinking about broadband for public and nonprofit organizations, but we get pulled into the broader community issue. When we talk more about digital literacy, I think that's a key area, and I have some ideas that might be of interest to the group.
Hey, Jackie, I think you're muted.
I did it. I said I wasn't going to do that. Like, I have been on Zoom solid for 6 months, and here I am. You missed that really eloquent introduction, so let me repeat it one more time. It is my pleasure to introduce Terrell Graham, who is currently a fellow at Emory University and also simultaneously getting his Doctor of Philosophy at the Harvard School of Public Health. So moment of silence for this man's multitasking skills, because that's incredible. Terrell is a Yale School of Public Health alum, where he received a master's in health policy and management with a concentration in global health. He has worked at the CDC and as a policy advisor at the U.S. Department of State before assuming his current position as a visiting fellow of strategy and innovation at the Emory University School of Medicine. He also happens to have secret clearance from the government, which is something that we touched on earlier. And that's a completely separate, fascinating discussion that we can have at another time. But today, could you tell us a little bit why this particular track is important to you?
Sure. Thank you for that riveting introduction, Jackie. So what I'll say is that I am originally from rural Jamaica, and spent my early years growing up on a farm, basically. So that kind of attuned me to the experience of living in rural spaces. However, fast forward about 20 years, I saw how not having regular access to health providers impacted the life and the latter years of my grandparents. So that kind of got me interested in how digital health and things like telemedicine and such can reduce geographic barriers in terms of providing health. Fundamentally, I see it as a health equity issue. And I've become really interested in addressing things like the digital divide and such things. So that's what brought me into, looking into this field.
Great. Thank you very much.
No, thank you.
Next, I'd like to introduce Aaliyah Aaron, MSHS BSN RN, who is the founder and CEO of Nursing Innovation Hub Incorporated. This is a healthcare innovation company with a virtual incubator, accelerator, and digital platform matching nurses, developers, design engineers, partners, investors, and collaborators together to drive innovation in healthcare with the use of technology. And she also runs her very own podcast, which covers nursing innovation. So, Aaliyah, can you tell us a little bit about why rural and low resource health is important to you?
Sure. Hi, everyone. Thanks for having me on. Thanks for joining, listening in. So this topic is of course dear to my heart because not only am I a nurse, I'm a minority, a woman, and I grew up in the inner city, but I have family, friends, and I take care of patients when I was a critical care and trauma nurse in and of areas that were of low economic status or in rural areas. I've worked in various hospitals across the U.S. as well as hospitals globally where they're underprivileged and underserved. And so, as a nurse, as a technologist, as an enthusiast in this area, I am very encouraged to utilize technology to leverage improvements in healthcare, particularly through to those that are in areas that are less fortunate, those that are not have access to care as the bigger cities and so forth. And so, one of my initiatives through graduate school and beyond has always been the eradication of healthcare disparities. And working in technology has allowed me to be able to develop new technologies that can and incorporate measures where we can help to really eradicate those disparities through new technology development and including those minorities in the development of those new technologies.
All right. Thank you very much. All right, next I'd like to introduce Juan Barraza, who I just mispronounced his last name because I have a horrible inability to roll my R's. So I apologize for that. But I will not apologize for the awesomeness of his job. He is the Director of Student Innovation at Portland State University, a university which has been highly regarded for its national reputation and innovation. So Mr. Barraza is a creative entrepreneur with proven marketing skills. He has over 14 years of experience building teams to grow market share, expertise developing outreach programs designed to engage underrepresented entrepreneurs, as well as providing education in the areas of team development, product building, and market fit. So Juan, if you could tell us a little bit more about why you chose to be engaged with the Inventathon and this track.
Absolutely, and thank you. And you rolled the R's perfectly, so it's just perfect. So it's great. Unfortunately enough, I get to work with university students, undergraduate and graduate students all across the university. We have a program called Invent Oregon that works with universities and colleges across the state. And the metropolitan areas across the country, but especially in Oregon, we are blessed with resources. And when I get to work with the students outside the metropolitan area in Eastern Oregon, Southern Oregon, Coos Bay, it's a lot of talent, it's a lot of innovation and entrepreneurship happening there. What is not available for them is the resources. The resources that we have here in the Portland metro area, they are not widely available. So what is inspiring for me is figure out how we can break down that barrier, how we can make resources available for innovators and entrepreneurs wherever they are. And our students, graduate and undergraduate students, already working in solving healthcare problems. We just have to connect the dots with the individuals that can provide mentorships and the resources that will make that invention and innovation possible. So Inventathon, that was playing right in my alley. I'm excited to hear where the pitch is going to be there today. And COVID has provided a silver lining to accelerate innovation across academia and how we teach and present innovative concepts and change the way we educate future students to the benefit of our country.
Very well spoken. All right, so now I'm going to turn to David Sheridan, MD, MCR. He is an assistant professor at Oregon Health and Science University and also co-founder of ProMedics Incorporated. Dr. Sheridan has to leave us at 2:50 to go save lives in the emergency room. So if you have any ED questions that you want to ask, let's try and get them at the front portion of today's panel. So Dr. Sheridan's current interests surround medical device development in two major areas: home health to decrease unnecessary medical visits, and ER critical care to improve the direct bedside care in those spaces. He has developed a lean methodology to forming problem statements, prototype development, and initial clinical testing with a number of ongoing products at his company, ProMedics. So that experience, that dual experience of being a faculty member as well as being a company director, how are you going to combine those expertise here today in this panel?
Thanks, Jackie. I'd like to talk to Terrell and really figure out special government clearance added to my my background. That's pretty amazing. So I'm a pediatric ER doctor, as you said, and so at OHSU we deal a lot with a pretty large catchment area in terms of rural health, where we get providers who don't take care of critically ill children very often, and so we can kind of assist with directing that care and then accepting the patients. And I think, as Juan and Darren mentioned, COVID has really changed things in terms of the breadth of telemedicine, and so I think there's a lot of really unique innovation opportunities to bring kind of the expertise at these large academic medical centers into smaller areas where maybe they don't take care of the select patients that we do. So I think it's a unique time to be interested in rural health and expanding kind of innovation and device development and telemedicine and various things like that.
Right. Thank you very much. And our last panelist, and I went in reverse alphabetical order for some of this. So Terry, this is the curse of being a B last name, is Dr. Terry Butler, who is the Associate Director of Outreach and Partnerships at We Reach Biomedical Entrepreneurship Center at the University of Washington. Dr. Butler has co-invented more than a dozen patents, managed nonprofits, and has held director-level positions at Soluxra, ITHS, and the Burek Center for Entrepreneurship, where she ran the Holloman Health Innovation Challenge. So, Dr. Butler, what brings you here today, and what attracts you to rural and low-resource setting in healthcare for today's panel?
Thank you, Jackie. Well, I'm really excited about supporting people in the region who are working on innovations. I enjoy working with students and investigators at institutions across the region, have great connections to a big database and Rolodex of mentors. So if people are looking for connections and looking to talk to experts or looking to talk to potential customers, to help them vet their ideas, I would be happy to help them. So I'm particularly interested in people who live in far-reaching areas and don't have access to experts who can help them when they're having a health issue. It makes a huge difference. And my mother had Parkinson's, and she lived outside of Boise, Idaho. And Boise had pretty good resources, but they didn't have leading edge access at the time. So we ended up bringing her over to OHSU, and she was able to get into a clinical study there very early on, and it really extended her life, and it improved her quality of life. So I'm very excited about the digital tools and how we'll be able to bring experts to people where they need them, when they need them. And I think it's a really exciting time for healthcare, and want to help in any way I can to get us through those bottlenecks. Thank you.
For sitting on the panel today. So since our room is really manageable in size, rather than having to moderate questions through the chat, I think we can just have individuals just mute their mics and ask their questions. If you would like, you can raise your hand and I can call on you, but you can also just feel free to throw those questions out there to our panel. Is there anybody that would like to start off with a question?
Hi, my name is Nicholas Van Nest, and my question is, I'm wondering how efficient or effective testing is in these rural areas. Like, I know that a lot of, one issue is like with sample stability, just what kind of obstacles are being faced, and just from, if any of the panelists want to jump in with solutions that they've seen that might have been effective. I'm just curious what you all have seen and what you've thought were great ideas. It'd be great to hear from you.
So when everybody jumps in all at once like this?
I was going to say, what in regards to what testing are you talking about?
Well, yeah. So, I mean, just general. Like, I don't have a medical background, so I'm more trying to understand the deficiencies in testing that are faced in rural areas specifically, or just obstacles to treatment.
Oh, okay. Well, in general, so hi, thanks for joining. In general, those that typically live in rural areas have low access to care because oftentimes there are very few physician practices located in those rural settings. Take, for instance, out in Southern California and some of the very rural regions, we actually worked with a hospital out there, which is one of the only hospital within a 150-mile radius. And so typically, the locals that live there are in that particular region. They're farmers. They work pretty much all day. They don't have the ability to drive hours away in case of emergencies and so forth. And so we like to leverage like technology to be able to, so telehealth, for instance, right? To be able to mitigate some of those patients that may need to seek care but are unable to get access to care right away. I think about a diabetic patient that lives in a rural setting who may not have a physician or nurse practitioner close by to help them manage and monitor their blood sugars on a consistent basis. So the use of telehealth, being able to have that communication set up where they can oftentimes get them connected to specialists in those areas that may be, miles away, but can talk to them to really help them understand diet, healthcare, lifestyle modifications that can help. There are a lot of challenges to those that live in those rural communities just because of lack of resources in those areas. We are spoiled for those that live in the city. We're spoiled to be able to have gas stations on every corner, banks and urgent care, standalone ER facilities. When you live in a very rural community, your ER may also be your urgent care, a small school for it's pretty much everything. The patients that come in, they in with them because there are not a lot of daycares in the areas, and so they are the ERs in those rural communities pretty much take care of the entire hospital. So there are a lot of challenges, but those that live in those areas, they have they seem to be accustomed to healthcare in that region, just based on familiarity, right? We have in one hospital in a rural setting, we have a physician that lives out of the country that flies in once a month to do surgeries. And this is how it's been for years. But this is access to care, right? This is what we're talking about.
So it sounds a little bit like there are points of care, but it's a distance issue in addition to the resources issue that are compounding the rural and low resource areas. Panelists, do you have any other thoughts about how testing in specific might be difficult in this arena?
You have to, if we're talking about COVID, and this is just the latest sample, right? You have to take under consideration how the communication gets disseminated for populations don't have access to digital resources, right? Here in Oregon, the Latino community has been affected in higher numbers of percentage compared with the rest of the population because cultural issues, the communication wasn't widely available in English and Spanish, and they were the last ones to be able to get the know-how and why. So when we're talking about testing, you have to take under consideration how we're disseminating information. The first go-to is telehealth, digital communications. What about those folks, right? They are not technological savvy, or they are not utilizing technology like we're using right now. It's something to take under consideration, not just for this pandemic of healthcare in general, but moving forward.
I think the other thing I would add is that there's the patient side of things that we're talking about, but in a lot of these rural communities, we get calls in the ER a lot that say a kid with some weird congenital heart disease that they have never seen before in their lives shows up in their ER and they get these tests and then they don't know what to do with them just because they don't take care of these complex patients very much. So there's the whole side of providers who are working in these communities taking care of every single patient, because it's a big catchment area, who I think kind of need a little bit more support too, and like what's the best evidence about when to image somebody or obtain tests. And so there's that kind of whole side of things about how we can kind of help providers as well, because you might not have a provider who's fellowship trained or something like that. You may have more of a mid-level provider who's trying to care for this huge catchment of patients.
And this is Steve Corbato. I'll put a thought in here, and really thinking about if I had a startup and I were trying to design to various network capacities, we're putting a lot of emphasis on making sure that we get high-speed connectivity to rural hospitals and rural clinics. So if that, and obviously that allows for the transfer of imaging data, high quality video conferences. But if you're thinking more in health application, and real-time patient monitoring and the like, that's a tougher challenge right now. And we'll talk about some of the technologies that are on the horizon, but it's in this country right now where we assume that that a broadband connection is 25 megabits per second up and 3 megabits or 25 megabits per second down and 3 meg up. That's tough for many applications. And I think if I had a startup right now, I'd be thinking about how to get in front of the curve with some of the newer broadband technologies that quite frankly, I think we're going to see significant state and federal investment over the next few years in deploying.
All right, Darren, you had one thing that you wanted to add?
Yeah, I'm not sure if part of the question implied like biologic specimens. I thought I might have heard that in the question in terms of when you need to send a lab from a rural environment to a more urban environment to get an assay done or a biomedical lab done. How long does the blood or urine or sputum or other tissue stay preserved? And I think I heard that in the question. And I'm not one to answer that, but I wonder if anybody else has any knowledge about that. Is that a challenge in terms of getting labs processed? Or do we have enough hubs in rural areas that the labs can be handled if they're put on ice or dry ice, that things still get taken care of? And I don't know the answer to that, but I think that was built into the question as well, perhaps.
Any panelists with insight on that?
Well, I wanted to say
there are definitely challenges with labs being having a speedy, time to result. Because when you think about it, in order to get the labs resulted, unless they're resulting those labs in-house, which most likely they are not, they have to be sent out for specimen analysis. And those diagnostic entities that typically do specimen analysis are located in larger areas, right? They're not typically in those rural areas. And so there's a time lapse, right? There's time to, they can draw the labs at the facility or at a designated research site, a COVID setup site, but then they have to be transferred out for analysis and then sent back over via some sort of technology to the facilities or so they can get the correct patient information. So there is definitely a time in between, as opposed to, here I live in Fort Lauderdale area and I can go get tested and get same day results.
Okay, Terry, I believe you had something that you wanted to add?
Yeah, just say that innovators are addressing the technology issues, like things you now need a full tube of blood for. You need to go get a blood draw somewhere at a medical qualified site and then have that sent on ice to a test lab. But now people are working on microfluidic systems and point of care kits. And so kits will go out to a person, and with easy instructions, a lot of these kits, people conduct their own tests with pinprick type blood samples or urine samples. So that's something for innovators to think about as grab onto some of these new technologies. There's a company out of Texas that's still considered a startup, I guess, called Everlywell, and they've developed some really fabulous kits where you can test for all sorts of food sensitivities, and they have COVID tests etc. So that's one way where people who are distant can get something transported to them and then send it out to a lab quickly.
Great. Thank you.
Mhm.
All right, so we have a couple of questions in the queue. I'm going to go with Nguyen's next. What logistical challenges do remote rural areas face in regards to the supply chain of PPE equipment and systems? So we've touched a tiny bit about just access to broadband, but how does this get more complex when we're looking at like that essential PPE and other necessary equipment?
I can speak to that a little bit. And I think at the beginning, our supply chains was disrupted. We were not ready for that. And overseeing that, we were not set up to have manufacturing here in the country. We help set up, for example, for 3D printed face masks for healthcare providers. So supply chain, I think having a foresight of being able to have enough within the region and being able to manufacture in the region is a big challenge that we're facing right now.
Yeah, and so one of the things you have to think about is, if we think pre-COVID, healthcare in general, we were at a deficit, right? So, like I said, my background is trauma and critical care and ED nursing. Prior to COVID, we were already at a deficit where we're running short on staff, we're running short on supplies, right? Hospital budgets are tight. So when you think about how COVID has impacted the healthcare supply chain, there's a huge impact to that, because not only are the rural healthcare environments starting off in a deficit, now this is really stretching them because their opportunity to get additional resources, right? So when we talk about PPE, PPE is used for the clinicians, right? So the need for additional clinicians is already stretched. So their budgets are very, very tight. And oftentimes rural healthcare facilities run a very streamlined resource pool and budget pool. And so they are very, I want to say they're already, right, in a deficit starting off as it relates to COVID, because they were not in a position to really handle their current state due to lack of resources, due to distance to large facilities, due to budget constraints and so forth and so on. And then oftentimes as well, the rural facilities, I think Juan mentioned this as well, you have to consider those that live in that area. Oftentimes there are language barriers, and so they have to bring in additional resources to be able to communicate. I've worked in many areas in rural settings where the children are the only ones that speak English.
Mm-hmm.
So when we talk about innovation, we have to consider all of those, all of those areas to really help improve how we can bring healthcare to those areas, because it's really about patient outcomes and looking at clinician satisfaction, and everything has to be considered, because you can't just bring a truck of PPE and say, all right, here's your mask and gowns, but if you're looking around like, well, where's the clinicians?
Mm-hmm. Excellent point. All right, I would like to give Manu a chance to ask their question. If you could unmute yourself and give it a go.
Yeah, sorry, I didn't have more of a question. I thought this was kind of like bringing your ideas in, and that's why I kind of raised my hand and then lowered my hand. But I just wanted to let you know, guys, that one of the partial thing about the telemedicine that I'm working on as a pitch is basically to eradicate the not eradicate, but to reduce the language barrier and distance barrier, because one of the apps that we are proposing is to have the intuitive piece to reduce the technology dependency of non-technological people, uneducated, visually blind. So the app that we are proposing is so that you can talk into it, tell your symptoms in your native language, and it will translate to whoever is on the doctor on the other side using natural language processing to elevate that bit portion of it. So sorry, I'm probably in the wrong place telling this, but
No, thank you for sharing. NLP is one of my favorite things. So if we could get NLP to help bridge some of the divide between communication, that would be wonderful. But unfortunately, NLP and Amazon is telling me to buy a whole bunch of stuff that I really don't need to. So still need to work out some kinks with that particular technology.
right. So
Uh,
one of the things, sorry, I just want to touch base. So we are an open source group and we are doing this for nonprofit. So that is one of the reasons there are a lot of folks who are trying to charge money. So what we are doing is we are working on a whole bunch of open sources. There are a lot of NLTK open languages that we are starting off with. So we don't have to, we are not promising you like the utopia model in the beginning, but we just wanted to at least start at a place where we can at least understand some basic terminology and at least get that. And we wanted to make it a cell phone app because it's everybody has a cell phone.
That is an interesting question that I think is actually up for debate.
Yes.
However, at this point in time, I want to make sure that
Sorry. Yes. I yield my time.
we have time for App to ask us an insurance question. So do you want to go ahead and ask the panelists?
All right. The name is Carl. I'm sorry. The app is my email address, so I apologize about that. Just want to give a shout out to Aaliyah Aaron. It's good to see you on here. I know her very well. So the question is that I came up with a problem related to nutrition and being readmitted into hospitals. And we came up with a really good app concept where we will essentially have the end user order meal plans that are backed by a nutritionist. The question that I had in regards to insurance, when the end user picks their meal plan based upon a diagnosis, so if you're diabetic, again, it will calculate appropriate meal plan. Will insurance pay for that meal plan very similar to when a provider does a medication reconciliation, right? Insurance companies help with paying for the medications. Do insurance companies pay for or help pay for meal plans upon discharge?
So I'm not an insurance expert, but what I can say is when a patient is, take for instance a patient that came in through the ED, was admitted to acute care, and now is being discharged to home with a discharge plan where they need to follow up with a nutritionist 3 or 4 times a week with a modified diet. Based on what the insurance plan that the patient is on, and based on how the physician writes the order and what it's for, because everything has to be connected to the patient's underlying condition, right? If the patient is being discharged home and nutrition is not one of their hospitalization, reasons, right? And they're going to be put on some sort of meal planning. If they came in with, let's say, CHF, right? Their typical discharge would be a heart diet with a low sodium. But if they're being put on, some sort of nutrition plan unrelated to what the diagnosis was, then perhaps that may not be included in the insurance. Again, I'm not an insurance expert, so I would defer to someone that has more of an expertise. But I can tell you that the insurance is often related to what the underlying diagnosis is for the patient in order for it to be covered. Just like with physical therapy or speech therapy, the patient has had to have some sort of reason for it to be coded, or
Correct.
in order for it to be connected.
Right. And then just not to take up the conversation, but the end part of that is that, yes, in our solution, it's all these meal plans, and it's not just how a provider writes it on a piece of paper. I'm a type 2 diabetic. That happens to me. The issue that I identified was that that's not for someone who doesn't know how to cook, and I'm a traveling consultant, as you know. I would like a meal plan shipped to me that has pre-packed meals. And so because I'm being discharged, or my reason for visit is type 2 diabetes, I just wanted to know, and again, you answered it, will the insurance company reimburse the company that I went through or myself, just like they would with medications? But thank you for your insight.
No, sure.
I believe that
they follow up with just to get some more insight.
It looks like Terrell might have some additional information to add.
Sure. So while I was in Boston, there was an organization called Community Servants that was a part of the Food is Medicine Coalition, where they actually provide meals for patients with particular diseases or conditions, and they tailor those meals to them. The only difference is I think the payers that they mainly work with are like public payers, like Medicaid, Medicare, and I believe like the state of Massachusetts health program. So that may be one place you could look into for some more information. It's called the Food is Medicine Coalition, Carl.
Thank you very much.
Additionally, we have a comment in the chat from Scovington. It says, I'm a participant, but my background is in revenue cycle, so they might be able to assist you with that question, and you can connect with that individual directly on the Teams app.
Thank you.
We also have another question from Nguyen. Where can inventors look to find inspiration regarding that sweet spot between rural developed country and rural third world? How do our inventions scale between both of those worlds? She or he is adding that they've worked in construction BSL-3 and BSL-4 labs in rural Oregon, for example, but it was nothing like my experience in rural East Asia.
So I guess I'm just really trying to understand. They're looking for where the gap is from a third world country, their rural setting, as opposed to the United States rural setting. Is that kind of where we are with that?
I think they're trying to ask about how solutions might be able to scale between those very different environments. Both are classified as rural, but there are huge disparities even within that category of rural. So how might the pitches that are being proposed today, the solutions being proposed today, be able to bridge even that divide within the rural communities?
You have to, right now, for example, what you're doing with Inventathon is research, right? You do the market research. If it's a good fit what you're developing, it's an opportunity to develop your solution locally, and then you gotta ask yourself, and you have to do the research, how this solution can be applied in other settings. Definitely, the settings in the U.S. will be totally different than what you find in Asia or South America or Mexico. So you have to look what is the core features of your invention that you are developing and get out of the building. That's I can say you have to get out of the building. You have to go into those communities and figure out what you invented here in the US is applicable to Mexico or is applicable to America or Asia or Africa, right? And you have to look into the constraints that an environment that you have over there. We're talking about internet access right now. Some countries, all they have is flip phones, right? No smartphones, flip phones. And they have figured out a way to do e-commerce using just good old-fashioned flip phone and text messages, right? So it's getting out of the building and go to the more basic functionality of your prototype.
I love that. Get out of the building. That's so important. Steve, you have something that you'd like to add? You're on mute. Still on mute.
Mm-hmm.
Okay, he's motioning to continue on. I have a kind of question about that. So getting out into the community, that's tremendously important. Terry, I wanted to ask you, in your experience making all of those patents, how specific of a target population is really going to be the most helpful? Were your really targeted to a very, very narrow community, or were you able to create broader applicable inventions? I'm just curious.
You really have to get deeply into your end users and what's going on in their workflow or their lives or how they're going to use a product or service. And I would, I can't point to a study or statistics about this, but I would say most successful inventions start very narrow. And then when they are successful there, they start to look around and see where they can expand to. For instance, I guess a famous story is Airbnb. They wanted to have people be able to rent out their sofas to travelers so that artists and people who weren't rolling in money could afford to go to different cities and participate in these art shows. And they were told when they were in Y Combinator, you know, you need to focus on where this problem is the worst and who would be willing to give this a shot, because it sounds crazy to have strangers come and sleep on your sofa. So they went to New York City and they focused on particular people in New York City, and they got it working. And then they slowly expanded out, and then they learned that it was actually the presentation of the properties through good photos that made a huge difference in properties that were rented regularly versus not. So I think that most innovations they're great secret sauce and great success. They could not have anticipated at the very beginning, but by working very, very deeply with your hands-on with your users, get out of the building and get connected with those users, then you're going to reach success that you couldn't have even dreamed up yourself without working with those users.
So it sounds very much like getting out of the door and talking with the end users and developing a very specific relationship and use case with the users is going to best inform some really innovative solutions that you can scale up after that. So Darren has just put into the text box that Juan and Terry's comments really echo what we heard from the Hillrom Innovation Director yesterday regarding ethnography. If someone is looking for diverse rural populations, we may have many within the United States, such as Native American reservations, remote Alaskan populations, and island states and territories that may offer unique challenges that need solutions. Yeah, I absolutely agree. We've got a tremendous diversity of different populations, and each one of them has unique needs, and that is a challenge. Getting to know people is challenging even when we're all co-located in a really dense population. So going out and visiting rural populations and making sure that you can find an authentic connection, that's tough work. All right, so I wanted to see if there's any other questions from the audience.
Jackie, this is Steve. I'll come back in on that question now that I've got my audio issue addressed. If you're really trying to go for essentially a broad swath of developing countries right now, there is a prospect of a new connectivity technology that there's significant investment going in right now. We're starting to see some use cases being focused around low Earth orbit satellite, which a lot of interest, about 6 different entrants into that field. But it has the promise of providing much more ubiquitous connectivity, higher bandwidth, and particularly lower latency. So if you're thinking about a video conference, I think it's now the demonstrations that I've seen, it's now really possible to think about that compared to some of the traditional satellite technologies. I think there's a lot of interest in using that in the rural United States. Think about extreme southeastern Oregon, essentially the region south of Burns and east of Lakeview. There are some very remote ranching communities out there that, for most, there will not be an economic case for building broadband. The other piece I want to make reference to that with the tribes, the 9 tribes in Oregon are very active. They're very organized. They have a convening group through the University of Oregon that has actually been a vehicle for helping them understand some of the broadband opportunities. And we just saw yesterday that the FCC has actually gave preferred access to the tribes, essentially in the 2.5 gigahertz range, and 5 of the 9 Oregon tribes were able to get that access in the first round. So if you look to distance challenged and historically interconnected communities, there are definitely some opportunities in Oregon, but there are also some technologies on the horizon that may be a good bridge for a startup technology.
I have to say that this conversation has now covered top security clearance and low Earth satellites. So this truly has been a surprising panel from my perspective. Joe, one of our participants, points out that when we have questions about whether or not there is internet, we might in fact be missing a deeper question, which is technological literacy, which has been talked about a little bit earlier about the digital literacy, the digital divide. So how can we make sure that even if the technology is available, that we are communicating enough with the recipients of this technology that they can feel comfortable trusting new technologies that might be brand new to not only them, but their community with their health? So any thoughts on how we can improve that digital literacy, especially when it comes to such an important area of our own personal health and well-being?
Yeah, there has to be more emphasis on actually wanting to improve rural health as a whole. Because I've visited a lot of Indian reservations, out in South Dakota, where there's no access to internet. There's no street lights. There's not a lot there. So we have to be intentional when we talk about improving access to healthcare, because that is inclusive of education and educating the population as what does this mean, right? So we can't bring in 5G, 6G, or whatever that works and say, all right, now you have internet access, go ahead and hook yourself up and talk to a physician over in North Carolina and see what your problem is. Because if they don't, if they've never used the computer, or when we talk about patient education, consumer education around digital health and technologies, we have to start at a very elementary level, because you have to understand what they understand, or you have to understand what they don't understand in order to really educate them about technological advances. And we have to be very intentional of how we approach that subject, not to not to belittle those that live in those populations by using elementary language and elementary education to really help them. But oftentimes we have to do that in healthcare. We have to make sure that everything that is written out in healthcare can be understood by the population at whole, right? Mm-hmm. And not talk on a high level, but talk so if we're talking to a fourth grader, so they can understand it. Because a lot of times in those rural areas, like I said before, children have more opportunity and are able to translate to their parents to really help them understand some of these new technologies, because the school is teaching them.
Mm-hmm.
Sorry, Stephen and Dr. Volpe make two valid points. We don't invest in internet because sometimes the numbers and the surface don't pan out, right? The economics don't work out. But also the healthcare, right? We're thinking about how we improve digital literacy for healthcare, and the economics don't pan out. And I think we need to reframe how we see things, right? COVID, for example, has provided the silver lining for us to realize that internet access across the board is a necessity. It's something we all need to have, regardless if you live in a metropolitan area or a rural area. But we want to talk about economics. If we want to stop recurring patients coming back and being frequent flyers to hospitals or healthcare systems, we need to invest on that internet infrastructure to provide that digital literacy across the board. That way, the patients that have to go to the hospital to be educated about nutrition, how to handle diabetes, or the post care they need to have after the hospital, to avoid for them to going back to the hospital to being seen again and racking up the bills. That's the economics that I want to see, that I think we can make pencil out. I give an example of the dialysis companies, and maybe a bad analogy. Dialysis companies, many people that go to dialysis, they are uninsured. And the way they make it work, they insure them to be able to recoup some of the cost for the dialysis costs. So if we use that as, for example, we need to be able to invest in infrastructure, digital literacy, to be able to minimize the overall cost of healthcare.
All right, and thank you for those thoughts and insights. We have reached the end of our hour together. So to briefly summarize our conversation so far, we've discussed the fact that rural access is quite heterogeneous. There is availability for testing, for resources. If you can get there, there may be hundreds and hundreds of miles between resource access points, which changes the logistics behind care. When it comes to the pipeline, getting those necessary tests and PPE out there, there were disruptions in the pipeline. We've talked quite a bit about access to internet, access to broadband, and how that is something that people are working on, but it comes with a commensurate necessity to really also work on digital literacy, which takes us down the road of knowing the communities that you're working with. It's essential that we are really cognizant of the patron population that you're trying to serve. And importantly, that will help focus the innovations, because a narrower, tighter focus will ultimately produce a better innovation that can be subsequently scaled up and hopefully provide even broader impact. So there is a lot of great things to think about and take away from today's panel. I want to thank all of the panelists for your participation today. I hope that all of you are also signed up to be mentors. For those that are participating in the hackathon, please remember that you can request mentorship help at any time. If you go to the main tab, there should be information about how to request a mentor. I encourage you all to sign up for practice pitches both this evening and tomorrow morning. And I wish you all the best of luck of coming up with some amazing innovations. I look forward to seeing all of your presentations tomorrow, and I'm sure our panelists also are eager to see what kind of awesome ideas that you've come up with. So once again, thank you all for your time and attention. And as a last thing, please remember to take the questionnaire regarding the workshop. The link was dropped into the chat earlier, and I've just added it one more time. Your feedback will help us make this event better, but also make more awesome events in the future. All right, with that, thank you so much, and I hope the rest of you have a wonderful hackathon.
Thank you.
Thank you.
All right. Can we stop recording?